you for coming. Hopefully you guys all enjoyed a nice long holiday for President's Day. So today we have the second in a series of three with Dr. Puneet Pawha from our division of radiology, neuroradiology, and department radiology. If you guys remember, he came a few months ago to give us an intro talk for how to interpret a CT, and he's back now to give us share a little bit more knowledge with us. And today we're talking about ischemic stroke, acute stroke, I guess. Well, ischemic too.
Yeah, acute
right.
stroke.
Thank you very much.
Okay, great, thanks. Thanks for having me. Glad to be back here. And so this time we're going to be talking about stroke and how to look at CT in the setting of acute ischemic stroke, as opposed to hemorrhage, parenchymal or subarachnoid hemorrhage. So we're just talking about ischemic stroke. Last time when I talked to you guys, we talked a little bit about the basics. You guys may or may not remember. I think maybe next time we'll try to do them closer together. It might work better. But we talked a little bit about anatomy, mass effect herniations, and the main pathology that I discussed was hemorrhage, which is hyperdense or bright on CT. Now, if you guys, you probably know that CT is a density map. It essentially shows you whatever's more dense is brighter, and whatever's less dense is darker. So besides hemorrhage, though, most of the pathology we're going to see on CT is hypodense, is dark, essentially. And teasing those different disease processes out, it can be a little bit challenging, and it takes a little bit more knowledge going into it. So these are really, I think, best divided into stroke, which is such an important indication for non-contrast CT, and then other lesions. So the next time I meet with you guys, we'll talk a little bit about the other lesions. This time we'll talk about stroke. So we'll talk a little bit about the early CT signs of stroke. Primarily, we'll focus on MCA stroke. As you guys know, that accounts for about 75% of strokes, but we will talk a little bit about other stroke types as well. We'll talk about aspects when it comes to MCA score and treatment selection based on that. And then we'll talk a little bit about how to recognize whether a stroke is acute or chronic and what's the normal evolution of a stroke, and then a little bit about complications as well. So CT can be negative in the first 6 hours. It's certainly positive, majority of the time, 60 to 70%, even in 6 hours, but it certainly can be negative. That's always the classic teaching, that the stroke can be negative. Some of the first places we can see changes, though, however, are in the basal ganglia. I'll show you some examples of that. So those can be seen at 1 hour even. In about I think in a majority of cases, they are seen at 3 hours, changes in the basal ganglia with MCA stroke. Another early sign is dense vessel sign. Then we'll talk about some things like general loss of gray-white matter differentiation, parenchymal hypodensity or dark, essentially dark signal or appearance, and mass effect. And the first kind of manifestation of mass effect is sulcal effacement. And that's just, even if you have a small localized stroke in a certain area, that swelling will cause loss of the CSF containing sulcus in that area. So we'll look at a few examples of some of the early signs. Now, this is something called the insular ribbon sign. Can you guys can kind of jump in with this. You guys know what side the stroke is on? Can you tell? The right. So over here. So and that's also the the radiologic right is over here. And the reason why is exactly right is because we don't see the insular ribbon. So we look at the cortical ribbon all around the brain. The insula here is generally seen nicely on an axial image because you're kind of cutting it perpendicular to its trajectory. And so you should see a little bright signal here along the cortical ribbon. Underlying it is a little, a dark density, and then underlying that is more bright density. So it kind of has this layered lamellated appearance. And the brighter density here is the basal ganglia. This is the putamen specifically. This is the subinsular white matter. This is the insular cortex. So here, this is essentially just a manifestation of loss of gray-white matter differentiation, but because it's in the proximal MCA territory, and because the insula doesn't have as much collateral supply, it tends to be an early sign of an MCA infarct. So this is sometimes all that you see, and it may be difficult to pick up, but if you know where to look for the majority of strokes, which are MCA strokes, then you may pick this up and kind of know that it is positive. So here, this is the same patient 12 hours later, and you can see that it's progressed to an entire large territory MCA infarct. And this is what we're looking at here is, of course, hypodensity, so edema, loss of gray white matter differentiation. You have complete loss of the sulci over here. So we have the sylvian fissure on the other side. We have several sulci here that we can see on this image, losing all of that. And then as this progresses, we'll start to get further mass effect, effacement of the ventricle, things like that. Another example here, you can see a nice cortical ribbon along the insula here. We don't see it here. This is a little bit more of a clear-cut case than the last one. So again, because it's proximal MCA territory and it has a limited collateral supply, tends to be an early sign of acute stroke. So always look there first. And then this is 12 hours later, diffuse MCA territory infarction involving everything really except here the caudate, internal capsule, and putamen. That's the only thing that's spared in these cases. And that sometimes happens because there are perforating arteries that come off of the M1 that supply those nuclei. Okay, this is just an example of a small acute infarct somewhere else where we just have hypodensity involving the cortex and subcortical white matter, loss of gray white differentiation, similar to the insular ribbon sign, but can be anywhere. And something peripheral like this is probably due to embolus or something like that. So in this case, can you guys find the stroke? Well, you also know which side the infarct is on, so it's makes it easier. But what's the finding here? Anyone just kind of shout it out if you see anything that looks possibly abnormal. No points deducted for wrong guesses, So this is a really subtle one, and it's one that radiology residents miss all the time when they're starting out. And this is the vanishing basal ganglia. So essentially, what we're seeing here is, on the normal side, you see this density here for the caudate head and for the putamen, and you can see in relief the internal capsule here. So this is white matter, but this all looks the density of white matter here. So you really can't see distinctly the density of the caudate head or the putamen here. So it all kind of, this is essentially deep loss of gray white matter differentiation rather than cortical loss of gray white matter differentiation. So we're essentially just missing the basal ganglia on one side. It kind of looks similar to the white matter. So sometimes the hardest thing to see is what's not there. It's one of these eye test kind of things. But again, once you know what to look for, then you see these things. And actually, and so this is the MRI that was done, the diffusion, which shows the infarct over there. So yeah, as I was saying, so the majority of people with acute MCA infarct will have this, some basal ganglia changes visible even at 3 hours. So this is just actually overdid it with the windowing here, but but this is just to show you that a lot of just looking at a stroke CT and non-contrast CT depends on the windowing of it. And so what I always do, and what radiologists always do, is manually make the windows more contrasty, and that's called using a narrow window width. And essentially, you just do that with the mouse, and you can kind of see, play around with it and see which way makes it more contrasty. And that makes a big difference in differentiating gray and white matter. So, here, I mean, this is projecting overly washed out here, but this is supposed to be kind of a normal window width, and it's difficult to tell where the infarct is. But when you make it more contrasty, then you can see that you're missing the basal ganglia on one side. You can see here, here's the caudate head, here's the putamen over here, and the putamen on the other side, lentiform nucleus on the other side is partially missing. So this is really key in looking at these strokes. So if you're looking at a case late at night or trying to just see what the radiologist report is talking about, play with the mouse and make the windows contrasty as much as you can. It's another example here. So this is not only the insula, so this is subtle. This is not only the insula, so here you can see the cortical ribbon on the normal side. You lose it here. So it doesn't necessarily have to be frankly hypodense, but the first step in developing hypodensity, which comes from accumulating edema, is that the gray matter just becomes less dense than it normally is, and it becomes isodense or similar to the white matter. So that's why you have the loss of gray-white matter differentiation. You just have kind of a smudgy gray appearance. So this is kind of a common appearance of acute stroke on CT. So here, not only do you have the insula involved, but you actually have this gray smudgy appearance with some loss of gray-white matter differentiation in the operculum as well. And you compare that to some of the cortical ribbon that's visible on the other side, there's clearly a difference. And then this becomes much more obvious a day or two later, where we see this larger area of hypodensity, not only involving the insula, but also the frontotemporal and parietal opercula. So, as we were saying, all of these signs, loss of gray-white matter differentiation, parenchymal hypodensity that develops, and sulcal effacement, and progressive mass effect, which kind of peaks about 4 to 7 days later, are all manifestations of edema. And they're all actually cytotoxic edema. And so cytotoxic edema is exactly what it sounds like, edema related to cell death. And so, really when we look at CTs and MRIs, there are two types of cerebral edema that we try to differentiate between. So one is cytotoxic, and the other is vasogenic. So when we're talking about stroke, we're talking about cytotoxic edema, and the underlying pathology is that the NAK pump for the cells is not working, and basically there's passive accumulation of fluid into the cell. The cell swells up, as opposed to vasogenic edema, where there's disruption of blood-brain barrier, and essentially capillaries become leaky, and fluid leaks out of the capillaries and into the extracellular space. So in cytotoxic edema, we have intracellular fluid. In vasogenic edema, we have extracellular fluid. So if you look at the schematic, this is the normal case. Essentially, the fluid that we have is all within these swollen cells, and the extracellular space is very small, and it's very tight, actually. And that's why you have MRI shows you diffusion restriction, because that extracellular space is very tight, and fluid can't really diffuse there very easily. Whereas in vasogenic edema, you can see the spaces between cells are all increased, so increase in extracellular fluid, and that's why you don't have diffusion restriction on MRI. Vasogenic edema we see with tumor, abscess, and things like that. So, we'll see, but the key radiologic differentiator is that it only involves white matter, and you have preservation of the gray matter. So in fact, you may see the gray matter even better than you normally would. So we'll take a look at an example here. So here you have edema, hypodensity, swelling, loss of the sulci. There's mass effect in both of these processes. But here you have loss of gray-white differentiation. The gray matter is darker than it should be. So the cells within the gray matter are swollen and edematous as well. Here you actually have preservation of the gray matter. The hypodensity doesn't go all the way out to the brain periphery. And so that suggests that there's an underlying process here, such as maybe a metastatic lesion or an abscess or something like that. But this doesn't look like an infarct because the cortex overlying is preserved. And so here's another example of typical vasogenic edema. So with vasogenic edema, also it's described as having these finger-like processes, which is essentially just the subcortical white matter, which is edematous, and you see them in relief against the overlying cortex. So if you give contrast in this case, you see that there was an underlying mass here, which you couldn't see without contrast, but you know that this is a vasogenic edema pattern. This is not a stroke pattern. So and this comes up, for us, every couple of weeks we'll get a case that is a rule-out stroke, an acute stroke protocol, and it looks like a vasogenic edema pattern, and so we recommend an MRI, and we say it's not a stroke. So in this case, all right hemiparesis. So we're thinking there's a left-sided abnormality here, right? This is an acute stroke, acute right hemiparesis. Where's the stroke here? Where's the acute stroke? So this is going to be a tough one. So we see a lot of this patchy hypodensity within the white matter. We kind of see that in everyone. That's just kind of an aging brain. This is pretty dark here. This is probably a chronic lacunar infarct. This stuff is just the chronic white matter changes. Um, and the abnormality is right here, actually. So why is this causing right hemiparesis? Well, it's because of the location. So lacunar infarcts, and of course, if they're in the wrong place and in eloquent locations, they can have very dramatic presentations. And so this was an acute lacunar infarct, and we can really tell that for sure on the CT, but we can kind of suggest it based on the history and then recommend an MRI. But this is in the internal capsule. This is in the posterior limb of the internal capsule where the corticospinal tract is. So, this essentially causes almost the same deficit because all the fibers are packed in this tight descending tract in this location as you would have with kind of a more larger, cortical parietal, frontoparietal infarct. So over here, when you have, so because one of the key findings of stroke is loss of gray white matter differentiation, when you have a small infarct or especially a white matter infarct, it's hard because you don't have that, it doesn't really involve gray matter, so you can't really look at the gray matter to help you. But we know that in terms of lacunar infarcts, this is age indeterminate because it's not dark, it doesn't approach CSF like this one over here. So you have to have a high index of suspicion, know the location that you're looking for, and say that, okay, well, this right here is a little suspicious. It could not be an infarct, but it certainly could be an infarct. So, if it correlates with the clinical symptoms, think about it being an acute infarct and get an MRI. And this just to show you a schematic. So this was the abnormality here, and this is very high-priced real estate over here. So corticospinal tract. Here you have kind of the facial component, and this is the arm, thoracic, and lumbar components of the motor tracts. So you essentially have a complete dense hemiparesis, probably involving the arm and TL levels here from this tiny lesion. So as opposed to this one is a chronic lacunar infarct. So it's difficult sometimes to age things on CT as opposed to MR. However, when you have something approaching CSF density, you can be pretty confident that it's a chronic infarct, even when it's small like this. Really, the differentiator here becomes it's clearly not something that we can call chronic, but is it acute infarct or is it some of this just chronic small vessel ischemic change? So that sometimes becomes difficult. Okay, what side is the infarct on here? I don't know, for some reason, all of my cases have right-sided infarcts, except the last one, but they're mostly right-sided infarcts. So it's here, and the finding here, I think that there probably are some changes here, loss of gray-white matter differentiation, some mild hypodensity, but the real finding here is the dense vessel sign. So this is a really bright vessel, and if you look compared to the basilar artery and the left, this is the ICA essentially as it bifurcates into the M1 and the A1 over here. So this is the M1 we're looking at. So it's a little bit subtle, and definitely this can be a subtle sign, and sometimes we go back and forth about them. But if you compare this vessel to these two vessels, certainly looks brighter. And what we're looking at here is the clot, the fresh clot, and you're actually directly visualizing it. So this can actually be the earliest sign, because before you have any frankable changes, you have the thrombosis, right? So and you have the clot. So this can be the earliest sign before you see anything else. This is another example, more subtle actually, because it's not as dense, but when you compare it to the other vessels that you see, the basilar artery, the other proximal MCA we get a little glimpse of here, it is brighter. And so if it correlates with the side of symptoms, have a low threshold for this.
Why is brighter?
So this acute clot is bright. It just is. It's increased density compared to flowing blood. So the rest of the vessels you're looking at have flowing blood. But there are some pitfalls here. So this is essentially what we're looking at. This is a CTA, and you see the filling defect here. So if you see kind of a dense vessel right there, this is what you expect to see on CTA or MRA. So this is MRA2 with similar. I think this is almost the same. This is a different patient, but it's almost the same lesion here with this M1 here, and in the very proximal M2, you have this filling defect. So you do have to be a little bit careful with this sign. people, when they first start to look for the sign, they definitely overcall it because it really has to be asymmetrically denser than the other side, and you can also use a basilar as a comparison. But you can have atherosclerotic microcalcification that can cause a vessel to look dense, and then that's probably the most common false positive with this. You can also just have generalized increased density of the vessels if the patient has a high hematocrit level, or in younger patients they have just denser circulating blood. But that's why it really has to be asymmetric, and you have to really look at the other vessels and see that it's really a focal abnormality. Another very useful thing to do is look at thin sections. So, when you get on almost all of our scanners, when you get a head CT, we have the axials, the routine axials, and we have coronals and sagittals, basically the same data, just reformatted in different planes. So those all help, but then there's also one series that has many more images. So usual head CT will have 35 images, but you'll see one will have 250 images or something like that. So these are basically the source data, the thin submillimeter volumetric slices. And this is great for looking for dense vessels. So you look at those and you can really see that, okay, this is clearly much different than the other ones, and it's clearly not calcium as much as we can tell. Sometimes microcalcifications you can't really tell, but if it's a more coarser or macrocalcification, you can tell on the thin images. So those are extremely helpful in looking for dense vessels. One of the other things that kind of limits your evaluation to look for dense vessels is presence of contrast. So, if you have intracranial contrast from a CTA that was done, earlier today, or maybe the patient already went for angiogram or something like that, all the circulating blood pool is going to look a little bright, and it's going to basically mask the dense vessel. So, just this rolls into you really don't need contrast when you're evaluating from acute CT, acute stroke with CT. Infarcts don't enhance acutely, so there's really not much added to it. They can enhance subacutely, and that actually confounds the whole situation, because sometimes, if you image a few days later, you can see this, bulky enhancement along the cortex, and then, invariably someone will say, how do you know that that's not a tumor and how it's not something else and something else? And, it's just not, because that's how it looks. But, it kind of confuses the whole situation. So it really doesn't add anything. And it, again, obscures the dense vessel sign. And it can also obscure hemorrhage, if there's petechial hemorrhage or frank hemorrhagic transformation. If it's a frank hematoma, it shouldn't be obscured by contrast, but if there's mild petechial hemorrhage, it certainly can reduce the sensitivity for that. And then, as you all know, non-contrast CT is really key for treatment selection. If they're in the window to receive TPA, there's criteria that are based on the non-contrast head CT, like, of course, presence of hemorrhage, greater than 1/3 of the MCA territory being involved, and if there's more than that, they're more likely to have a poor outcome with TPA, and Spec Scoring, which we'll just talk about in a minute. So really, IV contrast is not needed unless you're doing CT angiography or CT perfusion, in which case many times we like to make sure we get a non-contrast head CT first, if one was not already obtained, and then do the contrast study. So contrast definitely is not always better. And you guys, I'm sure, are aware of all the time frames here, but for IV TPA, generally the time frame is 3 hours. There's kind of slightly lesser evidence for up to 4.5 hours. With intra-arterial, we can have longer time frames available for management, greater than 6 hours. And in terms of exclusion criteria for IV TPA, as we just kind of mentioned, presence of hemorrhage, more than 3 hours, and 1/3 of vascular territory of the MCA vascular territory being involved is a relative contraindication. These are all case by case as well. However, a lot of times now we are kind of moved towards, rather than just subjectively saying that, okay, 1/3 of the MCA territory is involved, we're using something called Spec Scoring, and we actually just started routinely putting these. So you probably have seen that if you've kind of looked at acute stroke protocol CTs. So we don't put this in routinely in our normal CTs or our follow-up for stroke, but if something is done as an acute stroke protocol, then we actually give a aspect scoring as part of the report. So what aspect scoring is essentially 10 points are given to the various branches of the MCA territory. And there are 4 at the ganglionic level where you see the ventricles, and that they correspond to the caudate, lentiform, insula, and internal capsule, which is back here, this dark area here. And then there are 3 lower MCA cortical sections and 3 upper MCA cortical sections. So the upper ones are above the level where you would see the basal ganglia and see the ventricles, essentially. So 4 for the essentially gangliocapsular regions and 6 for the peripheral MCA regions. So if you have, and with this scoring system, essentially you deduct a point for every zone involved. So a 10 is a perfect score. So 10 is a normal head CT. If they have, if you, just like the case we saw before, if they just have an insular ribbon sign, then that's a 9. You know, if they have involvement of the caudate, lentiform, and insula, then that becomes a 7 because you deduct 3. So, 8 or above, they generally do pretty well with TPA. When it's kind of 6 to 7, it's a little bit questionable, but possible, and kind of depends on the whole clinical scenario. But below 6, they tend to have more complications and more incidence of hemorrhage. So, so very useful, and we're kind of incorporating this, and you'll kind of see these in the reports now. Yep. In terms of the main, in general, intraarterial is better, of course, because it's more targeted and can be taken out to a longer window. But in terms of the risk for hemorrhage, I'm not sure what the numbers are and the differences between the two. Okay, so this one, this is just an example of a pretty severe stroke, and this would get an aspect score of 3. So we have essentially only 3 zones that are spared. So we're deducting 7 points here for all of the 6 cortical MCA segments plus the insula. But we have sparing of the caudate, lentiform, and internal capsule. So this is already very severe. It's kind of cat's out of the bag here, and not really going to benefit that much from treatment. So here, different case, moving on here. Which side is the stroke on? Right or left? So, yes, exactly. So, you see exactly. So you see the bright cortex here. So you look at the periphery of the brain and, see if there's an asymmetry. So if you see this bright stuff here, okay, the cortex is preserved. You're not seeing that here. You're not seeing that. 1, it's not as bright, and 2, you're just not seeing the difference between the gray and white matter. You're also not seeing sulci as well, right? So here you see sulci pretty well. There's a degree of atrophy here. Here you're not. But so what territory is this now? So this is not just an MCA, because here, clearly there's some MCA. You have this frontal area involved, but the MCA territory does not go all the way medially here, right? So this medial strip here is actually the ACA territory, and this is a little bit later, maybe a week later, and we see this much more well-defined here, clearly an MCA stroke here, but we also have the ACA territory. So that medial strip that's parasagittal in the frontal, to the anterior parietal, is all ACA territory. And here is just kind of a map of the territories. So, if you have something that involves more than one territory, then you have to start to think about, okay, why are more than one territories involved? What is the underlying vessel involved? What is the underlying process involved? So back here is PCA territory, and then this yellow area here is actually anterior choroidal, which is a very important, very small vessel, but very important because it supplies part of the internal capsule with the corticospinal tract. So you can see here that this is clearly involving both ACA and MCA territories, the case we just looked at. So, and this is MR in the same patient. as it progressed, and this whole area. If you see it extending all the way up to the falx, that's definitely ACA. And so what pathology is going to cause ACA and MCA territory? I mean, clearly if you have just ACA or MCA or PCA, that vessel is involved. But if you have ACA and MCA, those are both anterior circulation vessels, so you're going to have some pathology with the internal carotid artery. And so here we have the internal carotid artery on the normal side is preserved here, and then we just lose it all together over here. So we see a little bit of it, then we just lose it. So it's an internal carotid artery thrombosis. And then you see a little bit of trickle of flow in the distal vessels here. So here is a kind of a very large, complete MCA territory infarct, and it just kind of shows you the spared areas are the PCA and MCA territories. So this is MCA, this is ACA, and probably a little bit of anterior MCA here. And this is the PCA territory back here. So, kind of medial parieto-occipital, medial temporal is PCA. And in this case, you already start to see, you clearly have diffuse sulcal effacement, but you also start to have mass effect on the ventricle and midline shift as well. So the other kind of components of mass effect start to take hold after a few days. And then certainly they can develop herniation, subclausine herniation, uncal herniation, which typically peaks around 4 to 7 days. What territory is this one? PCA, yeah. So, this is the medial temporooccipital region, parieto-temporooccipital, and you have a little bit of the thalamus involved here, which the perforators come off of the basilar tip and the proximal PCA vessels, and they supply the thalamus. So, thalamus is really part of the PCA territory as well. People don't really think of that way, but it's really posterior circulation infarct. So this is kind of all the components of a PCA infarct in this case. And here you can see here that in the schematic, the thalamus is involved. So this is this is an example of watershed infarction. So when you have ischemic areas that are at the border of these vascular territory zones, then think of some type of watershed etiology, hypovolemia. Sometimes embolic disease can also hit the watershed area. So this doesn't really fit into either MCA or ACA. And typically, or classically, I should say, you may see a kind of dotted appearance, a string of pearls sign. So you have kind of an infarct, an infarct, an infarct, an infarct, and they all kind of line up in a row. So these are all basically at the border between two vascular territories. And I didn't actually have a good CT example on hand, but when you have different, this is a diffusion MRI, when you have varied territories, so on both sides, anterior and posterior circulation. So this is MCA territory, this is right PCA, right? This is right MCA, this is left MCA. Where is the source then? It's going to be something cardiac, most commonly AFib, but obviously there are many other causes as well. So bilateral, multiple territories, anterior and posterior, think of cardioembolic phenomena. So watershed, also can be related to embolic, but more commonly hypotension. If you have, we already talked about ICA, anterior circulation on one side, ACA and MCA being related to ICA pathology or even plaque from the carotid bulb, but on a unilateral side. But if you have something, another interesting case is if you have anterior and posterior circulation on just one side, that can be due to a variant called fetal origin of the PCA. So usually the PCA comes from the basilar artery, right? But in a minority of patients, and it's really not that uncommon. I don't remember the number, but it's probably in the range of 10% or even more. You have a very prominent posterior communicating artery that comes from the internal carotid artery that predominantly feeds the PCA. So essentially, the PCA is coming from the anterior circulation. So if you have essentially an MCA and a PCA infarct on one side, think about that as being the underlying etiology. Okay, and we mainly want to talk about anterior or supratentorial infarcts, but just quickly here, you can certainly have infarcts in the cerebellum with a discrete vascular territory. This is an example of superior cerebellar infarct. ICA infarct tends to be the anterolateral margin of the cerebellum, and this is a typical pica infarct with also involvement of the medulla. You might have something like a Wallenberg syndrome with this type of picture here. And the main clinical issues with posterior fossa infarction are, of course, cerebellar tonsillar herniation, if it's large enough, or develops hemorrhage, and narrowing of the fourth ventricle, which will give you obstructive hydro. So those are kind of the two main complications that we worry about with posterior fossa infarctions. And on the same topic, anyone see the abnormality here? This is again one of those things we said was potentially the earliest sign of an acute stroke, but in a different location. So this is a dense basilar sign. So here it's a little tougher because you don't have the other vessels to look at, as a comparison. But this basilar artery is thrombosed and it's too bright. And so you can also have that. We usually talk about it as dense MCA sign, but you can also have it in other vessels for sure. And you can even have it, distal to the M1 segment. Sometimes we see a dense M2 vessel. And that can be a very useful sign. So,
are there any CT protocols which actually give you the radiologist a quantitative reading of that, or is it just really just old school eyeballing densities relative to
it is eyeballing. It's pretty good when you look at the thin sections, and of course there's a lot of other findings that we put together with it. However, what happens is then you see the potential dense basilar, and then almost certainly they get a CTA afterwards, and then we kind of know for sure very, very quickly. But AI and machine learning is kind of really coming into radiology, and our section is kind of looking at a bunch of things. They just came out with something just to look for acute stroke, signs of acute stroke, with AI essentially. And so, it'll be one of these things where, it's going to take many iterations to get there. But, essentially what'll start happening probably is that, certain areas will be circled as potential abnormalities. And then, some of them will be real, some of them will not be. And then hopefully it'll get better over time. Okay. And then I wanted to just talk a little bit about how to decide whether an infarct is acute or chronic. So do we think this is acute or chronic? Chronic, and why? Right. So it's close to water. That's definitely a very important sign. However, the more important sign, there's one more reason why you can tell here, which is actually a more important sign.
Shift?
Yeah, no shift, but you may not have shift even in acute infarct. You might not get there yet, or it just may be small. But along those lines, you have actually volume loss. You have the opposite, right? So you have dilatation of this ventricle here. And this is the normal ventricle shape. You have the caudate here, and so here, because of adjacent volume loss, we call this ex-vacuodilatation. So essentially, dilatation due to volume loss in the adjacent parenchyma. So if you have evidence of volume loss, you know that you're in the chronic phase. Hypodensity is definitely a very good marker as well. However, if it's approaching CSF, then it's useful. A lot of times it's in the middle, and it becomes it's something that's indeterminate, because there's a range of people progress in different ways. Some people their parenchyma becomes hypodense quicker than others. So sometimes it just depends. Certain strokes in the same patient may kind of progress in density at different rates than others. So there's some overlap with that. So although that's very good when it's very dark, a lot of times in the intermediate phase it's indeterminate. But volume loss is really more definitive. So that's really the best way to tell. And here's a diffusion showing that this is not bright and confirms that it was a chronic infarct. And so just an example of infarct evolution. So this is at 3 hours. It's essentially normal in this case. And at 3 days, we see this well-defined infarct involving the striatum, so the caudate and the putamen. loss of the gray-white matter differentiation here between the internal capsule, and then there's some mass effect here, right? So there's some bulging into the frontal horn of the ventricle, and then this is at 3 months. So if you look here, the density is not that low here. So it would be hard to just use density, but you can clearly tell that there's volume loss. Just like the other case, the ventricle is ballooned out, and it's definitely chronic, even if you didn't have anything else to go by. If you didn't have this ballooning of the ventricle and you just had this hypodensity, it would be not as definitive for sure, because some patients get very hypodense even within a few days. And again, I think I mentioned to you guys that mass effect peaks from 4 to 7 days. So this is why we keep getting serial CTs, of course. And at this point, if you have a very large MCA infarct, you have to have neurosurgery involved and think about whether you want to do a craniectomy to decompress, to anticipate what's going to happen at 4 to 7 days. And here, clearly we have the diffuse edema. We also have complete effacement of the lateral ventricle. We have midline shift, self-pulsing herniation. We most likely have uncal herniation as well at this point, although it's not on the slice. This is an interesting one. So here, day 1, we see those signs that we talked about: hypodensity, loss of gray-white matter differentiation. It's so small that you can't really say about sulcal effacement, but clearly it looks like an acute infarct. This is day 10. So what happened on day 10? Exact same slice. Looks better. Looks like it went away. Maybe it resolved. Maybe it was. Usually when we see hypodensity on a CT, it's irreversible. Rarely you'll see cases where it's not. Maybe it wasn't really a stroke. Maybe it was some cerebritis, something like that. But it's usually at that point, if it's really a stroke, it's irreversible. So what happened here? We got an MRI to follow up and to see what was really going on with this missing stroke, and it's still there. So why don't we see it here? And this is something called fogging phenomenon, fogging effect. So essentially, at about 10 days to 14 days out, up to half of cases will have this to some degree, where you essentially have a pseudo-normalization of the density on CT, and that's just related to kind of increased protein and macrophages and things like that that come in there and kind of artificially increase the density back up to somewhat normal, and then if you image this a few days later, then it'll become more evident and become hypodense, and it will continue to a chronic looking infarct. So something that can really throw people off here, but it's a very interesting phenomenon, and we kind of see it all the time.
If you get your first CT at day 9, 10, you tend to say there's no stroke.
Yes, and then it could really be one. Yeah.
So a patient comes in and says, a few days ago I have some of these symptoms, you get a CT scan, that is negative, but doesn't necessarily mean that the patient didn't have a stroke.
If it's a larger stroke, you should see other some mass effect at that point, because it's a very small one here. You don't have the mass effect to rely on, and we've even seen this with lacunar infarcts too, that they just disappear around 10 days and then they kind of come back. So you can say that there wasn't a large stroke that has significant mass effect. However, there could be a stroke. You could get another follow-up after a few days to make sure that it's really negative. If the concern is that you want to see whether there was a small stroke. Okay, and in this case, this is another one where you have probably an ICA occlusion, right? Because you have anterior cerebral artery and and middle cerebral artery involved here. But in this case, we also have some little streaky densities here. Over here, here. So this is probably developing a little bit of petechial hemorrhage. And so this is also a kind of a complication that can happen in the subacute phase. And there are really kind of two types of hemorrhagic transformation. We generally think of petechial hemorrhage, which is basically just some leak because of the blood-brain barrier breakdown, and then more frank hematoma formation. So usually hemorrhagic transformation occurs within the first week, anywhere between the second to 14th day is most common. So proposed mechanisms are just reperfusion of injured tissue by recanalization, collateral supply, disruption of blood-brain barrier. To some degree, it's seen in 50% of patients, but that includes very minor petechial hemorrhages that may not be that clinically relevant. But 10% of those patients, and so 5% overall of patients with infarct, can have a frank hematoma develop. But even among those, much less are symptomatic from that hematoma, a little bit more so with TPA. Hemorrhagic transformation in general is more likely with cardioembolic etiologies, larger infarcts, and of course following TPA or anticoagulation. And some of the predictors for transformation after thrombolysis are a very proximal occlusion, a severe stroke by the NIH Stroke Scale, hypodensity greater than 1/3 MCA territory. That's why it's kind of a relative contraindication to TPA, delayed recanalization, and just if the patient is intrinsically doesn't have much collateral circulation based on his anatomy. Okay, this is clearly an MCA infarct. This is not sparing the basal ganglia. This is really kind of involving the entire MCA territory at this point. You can tell that this is not this did not occur just today because there's already so much mass effect. There's midline shift. There's the effacement of the lateral ventricle. So this is acute to subacute at this point. And this is the patient a few days later, frank hematoma. So this is not petechial hemorrhage, of course. This is a big frank hematoma, very devastating kind of outcome. And this is just a little bit of progression of sometimes how these things occur. First, you can have some streaky hyperdensities that are just along the cortex. In this case, they become a little bit more confluent after a couple of days, and this person then developed a really massive frank hematoma involving basically the entire MCA territory. So just this is the last case that I'm going to show, and which side is the abnormality on here? So it's getting some smiles. It's obviously a very diffuse abnormality. So it's this is a very unfortunate situation here. You have complete loss of gray white matter differentiation, hypodensity involving the entire supratentorial brain, no sulci, no ventricles, really no basilar cistern here as well. And then what we have is preservation of the cerebellum, right? So this is called the white cerebellum sign, and essentially it's just diffuse anoxic injury. You can also, with diffuse anoxic injury, just have basal ganglia involvement in some areas that have higher metabolic. But generally the hallmark for anoxic injury is kind of symmetric bilateral abnormality. So it can be bilateral basal ganglia. It can be even the hippocampus and the perirolandic areas as well, because they also have a little higher metabolic requirement. But in severe cases, you can have just very diffuse, entire cerebrum involved, and because and essentially the posterior circulation gets preserved in those cases. The brainstem and cerebellum tend to get preserved, and that's why the cerebellum looks relatively white. Essentially, it's just normal, and everything else is too dark. So this is kind of the most severe form. All right, so hopefully this was helpful for you guys. So just to summarize some of the points, the CT can be negative in the first 6 hours in about 30 to 40% of patients. Some of the very earliest signs you can see are dense vessel, which is directly visualizing the clot, vanishing basal ganglia, which is very hard to see. You got to really kind of play with the contrast and look for that, and insular ribbon sign. And then as things progress, some of the other early signs we see are just generalized loss of gray-white differentiation, hypodensity, and sulcal effacement. So, and these progress from very subtle in the beginning to kind of more established after a day or two. We talked a little bit about how to differentiate acute and chronic and kind of the normal progression of findings, and a little bit about the complications, particularly hemorrhage. So hopefully this was useful for you guys. Thanks a lot for having me.